So today we're going to be going over a bit of urology, urological malignancies, and see how we'll get on. I'm going to be asking a few questions along the way, so do your best to answer them if you can. So what we're going to cover today, we're going to go over BPH, lower urinary tract symptoms, prostate cancer, bladder cancer, and kidney cancer. It is quite a lot, but these are quite high yield topics for exams. Here's some stuff that I won't be going over today, but it is important topics that can come up in exams, particularly things like stone disease, UTIs, and emergencies. So I've just left that in there as a little checklist for you to go over in your own time. So starting off with the prostate. So does anyone want to hazard a guess as to which of those fruit or vegetables the prostate is most similar to in size?
A walnut?
Yeah, that's correct. Walnut. So it's a small prostate is it's a walnut-sized gland. It's found just below the bladder with the urethra passing through it. It consists of lobes as part of its gross anatomy and zones, which is its microanatomy. Because of the variation in descriptions and definitions of lobes, usually the zone classification is preferred. It's surrounded by a fibromuscular capsule and contains glandular tissue as well as connective tissue. And it produces fluid that forms part of semen. The peripheral zone makes up the majority of the gland. So you can see over here, posteriorly, so this is posterior and this is anterior. The central zone makes up around 20%, and then the transitional zone around 5%. So we said it produces fluid. Prostatic fluid is slightly alkaline, and the alkalinity of the semen helps neutralize the acidity of the vaginal tract, which prolongs the lifespan of sperm. So that's just a little bit of info about the prostate. So moving on to BPH. So BPH, so the two terms BPE and BPH used interchangeably. BPE means benign prostatic enlargement. This actually just defines the enlargement of the prostate, whereas benign prostatic hyperplasia describes the hyperplasia of the cells, and you can only really call it BPH after taking a biopsy. So that's a histological diagnosis, but for the purpose of exams, the two are used interchangeably. Around 42% of men from the age of 51 to 60 have BPH, and that goes up to around 82% of men from 71 to 80. So it's a very, very common condition. So essentially this describes the growth of the prostate gland, which causes bladder outlet obstruction, or BOO, presenting as lower urinary tract symptoms. It affects around 3 million men in the UK, and the prostate naturally enlarges with age. It increases in volume by around 2.4 cubic centimeters a year on average from 40 years of age. It's a hyperplastic process of the epithelial and stromal tissue. And it's thought that this is caused by shifts in age-related hormonal changes, creating androgen and estrogen imbalances, although this isn't 100% clarified. So the pathophysiology of BPH, it's an important concept to understand as a stroma epithelial ratio. And the obstruction is predominantly due to two main components. So the first component is the static component. This is related to an increase in the benign prostatic tissue, and this narrows the urethral lumen, creating a blockage. And there's also the dynamic component. So this is the increase in prostatic smooth muscle tone constricting around the urethra. Inside the prostate, there are alpha-1 receptors in the stromal tissue, and these are present in the prostatic capsule, stroma, and bladder neck. And this becomes important when we talk about management. So lower urinary tract symptoms can be divided into your storage symptoms and your voiding symptoms. And these are the type of symptoms which patients with BPH typically present with. So does anyone want to shout out what the two different types of symptoms are? Or anything in the chat at all?
Frequency and urgency. Not sure
Okay,
yet.
great. Those are types of what kind of LUTS?
Storage and voiding, so that's the two.
Yeah,
types.
perfect. So your storage and your voiding symptoms are your two different kinds of LUTS. So there's an acronym FUN to remember your storage symptoms. So frequency, so going multiple times, urgency, where they get the sudden feeling they need to go, and nocturia, so getting up more than 2 or 3 times in the night to go to the toilet, and voiding symptoms. So these are weak stream, intermittent stream, straining to urinate, and incomplete emptying. So the acronym you can see there used to remember that is FUN and WISE. And the reason for these, the storage symptoms are secondary to overactivity of the detrusor muscle of the bladder. And then the voiding symptoms are secondary to bladder neck obstruction. So those are the main symptoms of BPH. If you were to do a rectal exam on someone with BPH, it would reveal an enlarged smooth prostate gland. And if you do an abdominal exam, it may reveal bladder enlargement in patients with urinary retention. Patients can present with urinary retention if they have BPH, and they need urgent catheterization to relieve the pressure. And in urinary retention, a rectal exam should always be done men, but you shouldn't do the PSA because it may be raised anyway. So how do we investigate BPH? So you start off with something called the International Prostate Symptom Score, or the IPSS, and this can assess symptom severity. Essentially, its improvement and deterioration can be monitored once a baseline has been established, and it can be used alongside a quality of life score as well. You can also use bladder diaries. So this is volume charting, and it's used to record the time that they get up, the time they go to bed, the fluid intake, volume of urine that they pass each void, any incontinent episodes, and use of pads. So this is an example of bladder diary, and it's fairly self-explanatory, and the patient can fill it in throughout their day. You can do different scans. So ultrasound scan and CT scan are recommended in patients with a history of urinary tract surgery, recurrent UTIs, hematuria, any stone disease or renal insufficiency. And it may show things like hydronephrosis, a mass, or urolithiasis. So here on the CT scan, we can see that the renal pelvis on the left and the right hand side are very dilated, in keeping with bilateral hydronephrosis. And that will be due to an enlarged prostate causing back pressure going up to the kidneys. Cystoscopy is indicated in patients for direct visualization or intervention, as indicated following urinary tract imaging. This might reveal a mass, a stone, or a stricture. And uroflowmetry, it measures the peak urine flow rate, and this may vary with the age and amount voided. So this is just showing you how it's done. So essentially just having a wee into what looks like a bucket, and then it can record the flow rate. So you can see the red curve there is normal, and kind of the wave going up and down there is what it would look like if there was an obstruction. And then the purple line is kind of a plateau, and that's classic of a urethral stricture. And then lastly, urodynamic studies can measure the bladder pressures and muscle activity during the filling of the bladder and voiding. So that's investigations. On to management. So the main goal of managing BPH is to relieve the symptoms and improve quality of life. All patients should be advised on self-directed behavioural management programs, such as limitation of fluids, bladder training, and focused on times and complete voiding. Treatment of constipation will also help regulate urinary symptoms. Around 50% of patients get worse, around 30 remain stable, and 20 improve, but it's very difficult to say which patient will get better and which patient won't. And for some patients, if their symptoms are mild, it may be appropriate just to watch and wait and see what happens. So the management of BPH can be divided into medical and surgical. So we'll start off with medical. So does anyone want to shout out a class of drug which you can use for BPH management?
Alpha blocker?
Yeah, fantastic. So alpha blockers can be used. So some examples of these: doxazosin, alfuzosin, and tamsulosin. Tamsulosin is probably the most common of those. It's also an antihypertensive. And the way it works is it relaxes the smooth muscle of the prostate and the bladder neck. It works fairly rapidly because it acts on the receptors immediately, and it tends to be used in smaller prostates. There are some side effects. So we said it is an antihypertensive, so it can cause syncope, can also cause erectile dysfunction and some unwanted sexual symptoms. So that's alpha blockers. And then does anyone know another type of drug that we can use?
5-alpha reductase.
Yeah, perfect. 5-alpha reductase inhibitors. So examples of these, finasteride and dutasteride. Finasteride is the more common of the two. The way these work is it inhibits the conversion of testosterone to dihydrotestosterone, which is the active form. And the pathophysiological process of BPH is testosterone dependent. So if you're blocking the DHT, then it will slow down growth. It does take quite a while to improve symptoms because the aim of this management is to reduce the size of the prostate, and this can take several months, and it can be used as an add-on to alpha blockers. And some side effects, again, include impotence, reduced libido, breast tenderness, and gynecomastia. You can also use PDE5 inhibitors, so things like Viagra, which may improve lower urinary tract symptoms, erectile dysfunction, and quality of life. And these can be considered for patients with comorbid BPH and erectile dysfunction. So that's medical management. Surgical management now. Does someone want to shout out the gold standard? It's on the screen there as a clue.
TERP?
Yeah, TERP, brilliant. So TERP is the gold standard surgical procedure for BPH. So essentially during this procedure, tissue is removed from the prostate where it obstructs the urethra using a diathermy cutting loop. There are quite a few complications of TERP. So early complications are hemorrhage, sepsis, and something called TERP syndrome. TERP syndrome is quite a severe complication. It's massive cardiovascular collapse with hyponatremia and metabolic acidosis. This is the reason this happens is because of diffusion of the irrigation fluid into the circulatory system. Glycine is now used as irrigation fluid instead of normal saline because it's non-electrolytic and non-hemolytic, so that's the preferred solution. For patients unsuitable for TERP, they may require management with long-term catheters instead. And then some late complications. So retrograde ejaculation is very common, where the ejaculate goes back into the bladder. Impotence, strictures, and incontinence. There are also some newer options for treatment for BPH, and most of these are only offered at specialist centres. So the first one is called HOLEP, so holmium laser enucleation of the prostate, and you can see on the screen there. This is quite similar to a TERP, but it has a lower retreatment rate compared to TERP, and there's no risk of erectile dysfunction. There's something called a urolift. So urolift is pinning back the prostate tissue rather than removing it, and this also has good outcomes. This is called a RESM, and this uses steam vapor to shrink the prostate instead of the diathermy used in a TERP. And you can also have something called the green light laser. Again, this is quite a specialized treatment, and this it uses the laser therapy to clear the prostatic tissue. And you can also use prostatic artery embolization. But those are the newer treatments that I wouldn't worry about too much. As long as you know TERP and the medical management, you should do fine. Moving on to prostate cancer now. So prostate cancer, you might have seen in the news not too long ago, back in January, it's overtaken breast as the most common cancer now. The lifetime risk is about 1 in 8, and the peak diagnosis is in men aged 75 to 79. Only around 1% of patients are under the age of 50. It's not the worst cancer to have in the world, but it's not best either. So 1 year survival is around 94%. 5-year survival at 85%, and 10-year survival at 84%. So these patients still have good prognosis. Risk factors of prostate cancer. There are 3 quite well-established risk factors. These are age. Obviously, the older you get, the more likely you are to develop prostate cancer. Ethnicity, so it's far more common in Afro-Caribbeans and less common in Asians. And heredity as well, so it can be passed on in the family. And then there are some less established risks too, such as diet, lifestyle, and environmental factors. So the pathology of prostate cancer, most of them are adenocarcinomas, and the majority are in the peripheral zone at the back there, 70 to 80% of cancers. And you've got to think, if this is the posterior area of the patient and this is the anterior, the rectum is going to be here. So during a rectal exam, when the finger is here feeling the prostate, it will feel the posterior part of the gland. So you might be able to pick up any cancers in the peripheral zone. However, if there's a cancer in the transitional zone, this may not be palpable on examination. So just something to be aware of. Clinical features. The majority of the time it's asymptomatic. It's detected on PSA testing or incidentally on examination for other reasons. It may cause lower urinary tract symptoms, similar to BPH, can cause hematuria, and also bone pain. If there's bone pain, this is suggestive of metastatic disease. It's the first presentation in around 30% of patients, so it's not uncommon. And there are also systemic signs as well, such as weight loss, anemia, and lethargy. On examination, the prostate feels enlarged, hard, and craggy, and you lose the median groove, and there may be a palpable bladder as well if there's significant retention of urine. So how do we investigate prostate cancer? So starting with PSA, so prostate-specific antigen liquefies the ejaculate, increasing sperm motility. It's produced almost exclusively by the epithelium of the prostate gland. But it's neither very specific nor sensitive. So it can be quite difficult to reliably tell the difference between cancer and BPH. Only around 30% of men with a high PSA are found to have prostate cancer on biopsy. And then in men with a normal PSA, around 15% are found to have prostate cancer on biopsy. So really, it's most useful for surveillance after treatment. And PSA can be raised by a number of different things. So other than prostate cancer, does anyone want to shout out or put in the chat any reasons that PSA might be raised?
Someone says cycling.
Yep, cycling can increase PSA.
PR examination.
Yeah. Anything else?
BPH is another one.
Yeah, BPH, brilliant. So those are some great examples. So prostatitis, UTIs, BPH, acute urinary retention, catheters, cycling, and digital rectal exam. It's been noted in a lot of places that it says you shouldn't do a PSA after a rectal exam, and you should only ever do it before a rectal exam. However, there have been quite a few studies, I won't bore you by reading all of it, but the highlighted bits at the bottom that show that the difference in PSA following a rectal exam is so negligible that it doesn't actually have any clinical significance. So it's actually absolutely fine to take a PSA after a rectal exam. Okay. So in terms of normal values, an age-specific range is widely used. There's no screening currently, and there are various pros and cons of this. So pros include it improves early detection and reduces the rate of death from prostate cancer. But there are various cons. So we said it's not very sensitive or specific, and you risk overdiagnosis and overtreatment, which can cause morbidity. The normal values there are on the right. I personally wouldn't learn them for exams, and they should give them to you if it comes up in a question, but it's just useful to have a kind of a rough idea of the values. There are some circumstances where PSA should not be done. This includes if they've had a recent UTI, if they've ejaculated in the past 48 hours, if they've exercised vigorously in the past 48 hours. And it's also worth noting that finasteride approximately halves the PSA. So this can cause a falsely low PSA. MRI would be the next stage in investigation. So multiparametric MRI can identify lesions in the prostate, and you can see shown on the arrow there a diffuse lesion. Then the radiologist can give something called a PIRAD score from 1 to 5, and a score of 4 or 5 are probably malignant, 1 and 2 less likely. And then select patients will then go on to have a biopsy. So there are 2 different types of biopsy. There's the transrectal ultrasound guided biopsy, and that's the one on the left there. And then the transperineal template ultrasound guided biopsy. So that goes through the perineum, and that's the one on the right now. And the reason it's called a template biopsy is because there's a template placed there, which helps the accurate placement of the biopsy needle. The transperineal biopsy is they're tending to use it a bit more now because there are fewer risks and it's more sensitive, so the pickup rate is higher. And the main complication or risk to worry about with transrectal biopsy is sepsis in around 1 or 2% of cases. Classifying prostate cancer. Does someone want to shout out the grading system used? Anybody know?
Nothing in the chat, but I guess Dukes.
Okay, so not Dukes. Dukes is for colorectal cancer. It's the Gleason grading system is the most commonly used for histological grading of prostate cancer. So the way Gleason grading works is it's the sum of the 2 most common patterns of the cancer from 3 to 5. So Gleason 1 and 2 are no longer considered diagnostic for cancer. So therefore, the scores you can get range from 6 to 10. And those are the different Gleason groups. So you can have a 3+3, a 3+4, a 4+3, and so on. A 4+3 is a higher grade than a 3+4 because the 4 is, because if you have a 4+3, then the 4 is the most abundant type of tissue. I know this can be a bit confusing, but if you just remember that a 3+3, so a Gleason score of 6, is a lower grade cancer, and then a Gleason score of 5+5 or 5+4 is higher grade, then that should be fine. Going on to staging now. So it uses the TNM system. This can be performed using MRI, CT, and isotope bone scan. So a T1 and T2 cancers are confined to the prostate, and T3 and T4 are locally advanced. And this becomes important when discussing management. And then nodes, you can have N0 to 3, and this is just the absence or presence of lymph nodes. And then M0 or M1, and again, that's the absence or presence of distant metastases. And the most commonly metastasizes to the lumbar spine. So management of prostate cancer. So does anyone know the difference between, does anyone want to unmute themselves and be brave and explain the difference between active surveillance and watchful waiting? That's okay if no one does, I probably wouldn't. So active surveillance, this allows delayed primary treatment if there is evidence of disease progression. It avoids potential side effects of treatment in suitable men. And PSA is done every 3 months with a scan annually, and the risk of progression of the cancer is 30%. So this is appropriate where the patient needs treatment at any point, and it will usually aim to cure the cancer, but it's not called for just yet. It's only really suitable for men with slow growing cancer that hasn't spread outside the prostate and who would benefit from treatment such as surgery or radiotherapy if they needed it. And it usually involves more regular hospital tests than watchful waiting, such as the PSA and the MRI scans. Then watchful waiting, this allows delayed primary treatment if there is evidence of disease progression. It avoids potential side effects of, oh, hang on, I think I've done this wrong on the slides. So essentially, watchful waiting is, it's suitable for men with other health problems who may not benefit from treatment, such as surgery or radiotherapy, or whose cancer may never cause problems during their lifetime. It usually involves fewer tests than active surveillance, and these checkups usually take place at the GP surgery rather than the hospital. So watchful waiting would be kind of seeing and waiting to the point where the symptoms require some kind of management with things like palliative androgen deprivation therapy and radiotherapy. So that's not aiming to cure the cancer, it's more managing the symptoms. So surgery on prostate cancer. So this machine here is called a Da Vinci machine. They cost about £1 million, and some of the hospitals in the Mersey region have them. So the Royal has a couple of Da Vincis, so does Broad Green, and Arrow Park has some too. And these are used for prostate cancer surgeries. There's also newer robots this one's called Versius. This one's a little bit more practical and portable, so you can move it around from theatre to theatre more easily. And this just shows how prostate cancer surgery has evolved over the years. So it used to be open surgery, but this typically led to more complications, longer hospital stay, increased blood loss. Then it kind of went towards laparoscopic, but laparoscopic surgery in the pelvis is actually quite difficult skill to master. And now it's kind of gone on to robotic surgery. So the surgeon will sit in their chair there to the side of the patient while the robot's arms is doing everything to the patient. So the benefits of robotic surgery: blood loss, length of stay are significantly reduced, better functional outcomes. It has something called the endo wrist, which is far superior to conventional laparoscopic instruments because the wrists can bend back all the way on themselves. You have 3D vision inside your little booth, and the magnification is up to 10 times, and the ergonomics make much more sense. There are some risks of surgery though. So this includes impotence and incontinence, and then your other risks like bleeding, infection, and the risks of anaesthetic as well. Radiotherapy is an alternative to surgery. It has a similar cancer-specific survival to surgery, but there are no randomized controlled trials which prove its superiority. Pros of radiotherapy: it includes avoids the need for surgery, which means that it's suitable for patients unfit for surgery. There's less risk of incontinence, but there are some cons. So there is a small risk of secondary malignancy. It can cause cystitis and diarrhea, and PR bleeding as well. Androgen deprivation therapy is another type of treatment used for prostate cancer. So the aim with ADT is to cause tumor regression. Around 90% of testosterone in the body is produced by the testicles and 10% by the adrenals. It's often used alongside radiotherapy, but there are some side effects in keeping with the changes in the hormonal balance in the body. So it's important to understand the gonadal axis on the right that I've drawn out there. So the hypothalamus produces gonadotrophin releasing hormone. This then acts on the anterior pituitary to produce LH and FSH. FSH acts on Sertoli cells, and FSH acts on Sertoli cells, and LH acts on Leydig cells, which then results in testosterone production. And then the testosterone production causes negative feedback, reducing the amount of GnRH released, and so on. So the two kind of different drugs that are used as part of androgen deprivation therapy are LH-RH antagonists. So an example of this is degarelix. So this directly suppresses LH production. It works pretty rapidly and only for metastatic inpatient and renal failure, because it's quite a nasty drug really. So if it's blocking LH production, then it will therefore block testosterone production and aim to decrease the size of the prostate. The one which is a little bit more confusing to get your head around is the LH-RH agonists. So an example is goserelin, and Zoladex is the brand name. So if you're giving an LH-RH agonist, it may seem a bit counterintuitive because you'd expect this to trigger LH to be produced and more testosterone and so on and so forth. However, the pituitary eventually becomes desensitized and reduces overall LH production. Because it is an agonist, this can initially cause a flare, so an initial increase in LH, and this can last for a few weeks. So when you first give it, you need to give anti-androgens alongside it. I hope that made sense. It is quite a difficult concept to get your head around. So yeah, and you can also opt for a surgical procedure. So a bilateral subcapsular orchidectomy is effectively surgical castration to reduce the amount of testosterone and slow down the cancer. And last bit on prostate cancer, oncology and chemotherapy. So oncologists will work to find specific drugs that will help prolong survival in prostate cancer. And those are some of the examples of the drugs that are used. So who gets what kind of treatment? This is quite a difficult question to answer, and usually it's an MDT-led approach. But generally for T1 and T2 cancers, so these are localized to the prostate, they haven't spread yet, active surveillance, so waiting until it's appropriate to begin curative treatment, surgery, radiotherapy, and androgen deprivation therapy are the mainstay. If it's started advancing, so T3, T4, it's gone beyond the prostate, watchful waiting, particularly with patients with a life expectancy of less than 10 years, because there's a good chance that it won't be the cancer that kills them, radiotherapy and androgen deprivation therapy. And then if it's metastatic, the androgen deprivation therapy and chemotherapy are usually used as options. So we'll move on to bladder cancer now. So bladder cancer, there are around 10,000 new cases per year, and around 50% of those patients will die from the cancer. It's the 10th most common cancer in the UK and the 8th most common in men. And there are a variety of risk factors for developing bladder cancer. So age is a big risk factor. The older you get, the more likely you are to develop bladder cancer, as with many, many other cancers. Smoking greatly increases your risk around 2 to 4 times, and this is by far the most the biggest risk factor. Occupation, so there are certain industries such as using rubbers and dyes, paints and hairdressing that increase your risk. Cyclophosphamide, which is a drug used in rheumatoid arthritis, and pioglitazone, which is a diabetic drug, both increase your risk of bladder cancer. And chronic inflammation, so this may be in the form of schistosomiasis, long-term catheters or radiotherapy. Schistosomiasis is a parasitic worm infection that can cause chronic inflammation in the bladder. Pathology of prostate cancers, bladder cancers, sorry. So the most common is transitional cell carcinoma, around 90%, and this is almost exclusively smokers. You can also get squamous cell carcinomas, and schistosomiasis is the cause of this. You can also get adenocarcinomas and secondary cancers from metastases. Some clinical features of bladder cancer. The most common symptom is a painless hematuria, which is always cancer until proven otherwise. You can have symptoms of a UTI, so things like dysuria and frequency. Pelvic and back pain indicate metastatic disease usually. Diagnosis of bladder cancer is through cystoscopy. So this is just a camera into the bladder where the operator can identify the cancer. So you'll be familiar with 2-week wait referrals. So the 2-week wait referral criteria for hematuria shown there. So over the age of 45 with unexplained visible hematuria without a UTI, over the age of 45 with visible hematuria which persists or occurs after successful treatment for UTI, and over the age of 60 with non-visible hematuria with either dysuria or raised white cell count. These can be quite hard to remember, but I think the best way is to just sit down and learn your two-week criteria. So there are some terms used interchangeably with regards to hematuria. So if you hear the term frank hematuria, that's the same as visible. And if you hear microscopic hematuria, that's the same as non-visible. And it's important to mention whether it's painful or painless. If it's painful, it's more likely to be something like stone disease or an infection, UTI. Grading and staging bladder cancer. So you can have a high-grade cancer or a low-grade cancer, and you can have a muscle invasive or a non-muscle invasive, and the majority are non-muscle invasive. So again, it's the TNM system used, and you can see the picture on the right. It's quite a nice example of it. The first one to talk about is CIS, which is just carcinoma in situ. This is very superficial, so you may think that it might not cause many problems, but it's also very high grade, recurs a lot, and it's very aggressive. So this requires regular cystoscopies to check to see if it's progressed. And then T1 to T4 determines how far the tumour has invaded into the bladder wall and the muscle. Management of bladder cancer. So it's an MDT approach, as with prostate cancer. And really, management depends on whether or not it's muscle invasive. So if it's not muscle invasive, the gold standard is a transurethral resection of a bladder tumour, or a TURBT, and usually follow up at around 6 weeks with a cystoscopy to see if it's resolved. And then there are also options for intravesical chemotherapy. Intravesical just means that the chemotherapy is injected into the bladder. And the two main agents used are BCG and mitomycin C. BCG used to be used for quite a lot of cancers. The way it works is it recruits immune cells, but there are some side effects such as flu-like symptoms and cystitis. And mitomycin C, it heavily reduces the risk of recurrence by around 50%, although local inflammation can again cause frequency, urgency, hematuria, or pain. So those are your T1 cancers, the non-muscle invasive ones. Then your muscle invasive ones, the standard treatment is surgical. So a cystectomy, which is removal of the bladder and formation of the ileal conduit, which there's a picture of in a couple of slides, and I'll explain it. Or radiotherapy if they're not fit for surgery. And then metastatic disease is managed with symptomatic relief and palliative care. Prognosis of bladder cancer, survival is around 75% at 5 years for superficial tumours and around 20% at 5 years for muscle invasive tumours. So here's a video of a transurethral resection of a bladder tumour. If it's going to work. There we go. So you can see that's the tumour there. It kind of looks a bit like coral. And the instrument which just been introduced there is called a resectoscope. And essentially it just looks like the surgeon is shaving off the tumour using diathermy. And it's important to get good margins as well to not leave any tumour behind. And then all of those specimens will go to histopathology so they can undergo grading. Okay, so this was the cystectomy and ileal conduit formation that I mentioned. So if you have to remove the bladder, you need somewhere for the urine to go. So you can use the ileum as kind of like a makeshift bladder with a stoma, so it pours out into a bag. It's quite a complicated operation and takes quite a long time, but it has proven to be effective for muscle invasive bladder cancers. And last thing we'll talk about is renal cancer. So renal cancer, there are around 12,000 new cases and 4,000 deaths in the UK per year. That equates to around 12 deaths per day of renal cancer. It's the 7th most common cancer, the 5th most common in men, and the 8th most common in women. Incidence rates have increased by around 85% in the UK, so it's a rapidly increasing cancer. Lifetime risk is around 1 in 48 men and 1 in 83 women, and 40% present late. So risk factors for renal cancer, the biggest risk factor by a long way is obesity, which accounts for around 25% of cases. And you might remember recently in the news, there was a bit of backlash about that ad, which tried to get across that obesity is a big cause of cancer. And it definitely is the biggest cause of the biggest risk factor of renal cancer. And then other risk factors include smoking, hypertension, CKD dialysis, thyroid cancer, radiotherapy, and there's a familial link as well. Some genes which can increase your risk include the VHL, which stands for von Hippel-Lindau. The pathology of kidney cancer, the majority are renal cell carcinomas, of which clear cell is the most common type. There are also urothelium-based cancers, which include transitional cell carcinomas and squamous cell carcinomas. And then there are some rarer other ones. So sarcomas, Wilms tumors are tumors found in children, lymphomas, metastases, and so on. The clinical features of kidney cancer. So many signs and symptoms are only present in advanced disease, and it might be an incidental finding picked up on a scan for another reason. However, there is a classic triad which is described. So the classic triad is a painless hematuria, loin pain, and an abdominal mass. However, in reality, this triad is only found in around 10% of patients. You can also get systemic features, so weight loss, fatigue, pyrexia of unknown origin, a loss of appetite, and malaise. You can get bone pain, which may be suggestive of metastatic disease, and paraneoplastic syndromes, so hypercalcemia in around 25%, anemia, hyponatremia, and polycythemia. And lastly, signs of intravenous inferior vena cava obstruction, so things like bilateral lymphedema or a varicocele. Does anyone know why I've got this chest X-ray up, what this is showing?
Someone in the chat said cannonball metastases.
Yeah, brilliant. So this is cannonball mets. So you can get these kind of round lesions metastasizing to the lungs, and this can happen in renal cancer and testicular cancer, usually associated with a much worse prognosis because it's quite widespread at this point. But that's a buzzword for exams. Cannonball mets is linked to renal cancer. Investigating renal cancer. So you can do a urine sample and send it off for MCNS and dipstick it to see if there's any blood present. You might want to do some baseline bloods as well, but the mainstay is imaging. So ultrasound scan can identify a lesion, but not in great detail. So the gold standard really is a CT IV urogram. This uses contrast. It's a 3-phase contrast. And you can see on the scan there, identifying a lesion over there. Staging kidney cancer is using the TNM staging system. So T1 is less than 7 centimeters within the kidney. T2 is more than 7 centimeters in the kidney. T3 is any size going into Gerota's fascia or the renal vein or IBC. And Gerota's fascia is the fascia which surrounds the kidney. T4 is any size invading adjacent areas, which can include the adrenal gland. Management, again, is an MDT approach. And there are 2 routes, intent to cure and palliative. So the first option is surgical. Again, surgery can be done as open surgery, laparoscopic or robotic. And you can have partial versus radical nephrectomies. So a partial nephrectomy would be done if the cancer is small and easily accessible. And then a radical nephrectomy would be done if the cancer is spread or is very large. There are other options too, including active surveillance, so waiting until treatment is required, and then minimally invasive focal therapy, so things like cryotherapy and radiofrequency ablation. And then palliative options include chemotherapy, radiotherapy, and some newer drugs, including immunotherapy and biologics. And the 10-year survival of kidney cancer currently stands at around 50%. That kind of wraps up the content of the talk. We'll just finish it off by going over some MCQs and seeing how we all do. You can either put the answer in the chat or just write it down. I'll give you a few minutes, like half a minute for each question. So question number 1, which of the following is not a voiding symptom? Okay, we'll show the answer now. So the answer is nocturia. Nocturia is a storage symptom. We said that voiding symptoms are secondary to bladder outflow obstruction, and that the storage symptoms are secondary to overactivity of the detrusor muscle. So second question, Which risk factor is most strongly linked to bladder cancer? Okay, I'm going to show the answer now. So smoking is the answer, and it typically causes a transitional cell carcinoma, which form the majority of bladder cancers. Which zone or zones does prostate cancer most commonly affect? Okay, so the answer to this question is peripheral zone. So remember, this is the posterior zone, and it forms the majority of the prostate gland in the peripheral zone. Next question. A 59-year-old male presents to the urology clinic, having been referred by his GP. He has been complaining of passing blood in his urine on multiple occasions, as well as abdominal discomfort. He has felt under the weather and has lost around 2 kilograms in weight. On examination, there is a right-sided abdominal mass. He has no other comorbidities and has a good functional status. Given the likely diagnosis, what treatment option is he most likely to be offered first? Okay, so the correct answer to this is radical nephrectomy. So renal cell carcinoma, as we said, usually presents with a triad of hematuria, abdominal mass, and loin pain. There may be associated malaise and weight loss. Radiotherapy and chemotherapy may be offered, but renal cell carcinoma is quite resistant to these usually. So surgery is therefore the first line option. You can use biological therapies, but these are usually used for those with extensive or metastatic disease, or those with multiple comorbidities where surgery isn't appropriate. A 46-year-old African gentleman presents with painless hematuria. Whilst taking a urological history, he mentions that he has schistosoma hematobium, butchered that, infection in the past. What malignancy is he at increased risk of developing as a result?
Squamous cell?
That's correct, yeah. Squamous cell carcinoma of the bladder is the answer to that. Schistosomiasis is associated with SCC rather than TCC, which is more common in smokers. And then final question. You're discussing an elevated PSA result with one of your patients, a 62-year-old man with a PSA level of 10.2. What next step is the urologist most likely to recommend? A prostatectomy, a cystoscopy, a staging CT scan, an MRI, or a biopsy?
MRI.
Yep, MRI is correct. So prostatectomy would be far too mature at that stage. So a PSA of 10.2 doesn't really indicate whether it's cancerous or not. Cystoscopy isn't indicated at this stage either. MRI is the best form of imaging of the prostate. And then if that showed something suspicious or a high PIRAD score, then they'd go on to have a biopsy. So that's the correct answer. So thank you. That's the presentation. If you have any questions, just drop them in the chat and I'll do my best to answer them.